All right, so today we have Alex. She's going to be talking about adolescent substance use, something that is she's done a lot of in the past. So I've actually looked at this talk before, thought it was a great talk for this group. So we're happy to have her. That'll be coming up in just a few minutes.
We have other great talks coming up on February 12th. We have rapid inpatient methadone titrations, which will be wonderful. And then Kurt's going to be doing the next one on GLP-1s, which I think has been a really hot topic lately, not only for weight loss, but in the addiction medicine world. And then street medicine is coming up as well, which will be really fresh, new content. I'm excited to hear that one. Also, at the bottom of the screen, feel free to check out other echoes if you're wanting more continuing education credits.
I thought that said street tacos, and I was like really fired up. Street medicine. Okay. So, yeah, there's free CME. Just remember that. You have to please send back the thing that Katie sends to you. And as we say every week, please make sure that you flip on your video so Alex can talk to your face and not a black box in your name. We would appreciate that. Don't care if you're eating. That'd be just great.
As you all know, we're always here for you for technical assistance needs. Phone a friend if you have any interesting cases, you need help with policy or protocol, pretty much a catch-all. Our contact information is listed below. And Dr. Money, I have to say your plants are awesome.
All right. I just lost the video, so I can't see that. Is there another? Keep going.
Resources, don't reinvent the wheel. The core website through Stratus Health is available for you to check out if you want to look at workflows, policies, protocols, and any ideas as to how to shape your MOUD program.
Oh, and lastly, we have Alex's talk. And so I think, Katie, do you have to restart this, or is this where she can just pick up? And if so, perfect. Do you want to just take over, Alex, and maybe introduce yourself and tell us a little bit about yourself as well?
Yeah, absolutely. Nice to meet everyone. I'm Alex Stomikov. Please forgive my voice. I'm getting over whatever terrible bug was going around. I am a psychiatric nurse practitioner. I have been working in the addiction clinic here with Dr. Devine. I'm going to talk about adolescent substance use. Specifically, we'll talk about the most common substances adolescents are using, how it uniquely impacts their developing brains, and then we'll bridge into talking about how to assess for adolescent substance use when we can determine if that is in fact an addiction, and then what we do with that. So really a lot of this is curtailed to primary care providers, social workers. People are kind of at the forefront of this.
I have to tell you, oops, I'm sorry. No. Alex, I was just going to say, this is your opportunity to make fun of Kurt in front of everyone if you want to take it.
That'll happen. I'll integrate it into them.
I'm like, you work with him every day. Let's hear it.
I'll integrate it in. Anyway, I don't have any disclosures. I don't have any financial conflicts of interest. My background, just to speak to why I'm talking about adolescent substance use disorders, is I was a psychiatric child adolescent nurse by trade. I worked inpatient on the child psych unit for the University of Minnesota for 5 years before I got my doctorate, and then completed my year-long fellowship with the University of Iowa, which I make sure Kurt is aware of, is the superior place. I got all my addiction knowledge, more than he'll ever have there, Iowa. And I rotated between inpatient adolescent sites, some dual programs, and also was on our addiction consult service, our walking clinic, our MAT mobile. It was like a mobile addiction clinic, and then also outpatient. So that's my background. We can go to the next slide. I also want to reference that a lot of these slides are actually derived from PCSS. So that is the Provider Clinical Support Services. If no one is familiar, that is a SAMHSA government-funded program that is actually the program that offers that 8-hour DEA training for people to prescribe Suboxone. This is specifically their section on adolescent substance use. I obviously revamped a few things and put in mainly my own section about cannabis, but that is derived primarily from them. You can go to the next slide. Next. Do I need to? Oh, there we go. I also want everyone to see this PCSS website. This is really helpful. It's a free website if anyone else is interested. I know there's loads of resources we talk about on here too, but it's a way to get free CMEs. It's a way to complete your 8-hour DEA training, so you can also prescribe Suboxone. And then I circled at the bottom, you can request a mentor. You can actually message people online if you have any addiction-related questions. So just a cool website to also know about. Next slide. Okay, so topics and outcomes, we're going to talk about current trends pertaining to current substance use among adolescents. We'll go into pediatric neurobiology, substance use, how that impacts the developing brain. Specifically, I want to talk a bit about cannabis. We'll bridge next into screening tools you can use. How do we look for adolescent substance use if it's an addiction? What do you do next with that? How do you refer? What are some treatment options? My hopes is that at the end of this presentation, you'll be able to do the following: identify how brain development can increase substance use disorder risks, differentiate medicinal versus harmful impacts of cannabis, be able to apply a brief screening tool to assess for adolescent substance use or addiction, know when to identify if an adolescent should get referred to treatment, and be able to roughly list some treatment options, just what is out there. You can go to the next slide. Also, I should tell everyone, I speak really quickly, so we have a lot to get through. We're going to go through it quickly, but let me know if I need to slow down. Okay, so why we must talk about this, can go to the next slide. I'm sure a lot of us are aware of why we must talk about this. There's been a lot of avoidable deaths, not only in adults, but unfortunately in young people. A lot of it related to fentanyl exposure and unintentional overdoses. So you'll see my report about a Des Moines child, because I did this while I was in fellowship in Iowa, but also closer to home. There was a recent report of a 17-year-old girl in Isanti who had died, unfortunately, from a fentanyl overdose. This was correlated to over 127% of fentanyl seizures in Minnesota. So obviously strong correlation. As it's getting into our drug supply, it's leading to increasing deaths even in children. And as I'm about to go and spew a whole bunch of data at all of you, I want you to think about what these numbers, we're talking about children, we're talking about avoidable deaths. Specifically, when we think about this girl, I asked the following questions. I would wonder when her use of opioids started. I'd wonder when her treatment started, or if she'd ever gotten any treatment. And I wonder how many doctors she saw before that happened. And that's not at all to point fingers. It's just to think about how important it is if we are gatekeepers, if we are kind of that first line, detecting this can really be the matter of life and death. Next slide, please. Okay, so going into trends. So this is Monitoring the Future survey. This is a longitudinal survey that is taken in cohorts from grades 8, 10, and 12 that have been followed over time since the 90s. They interview 50,000 adolescents in these age ranges across the U.S. Again, I've been taking this data up until from the 90s to now. So really great information to pull related to substance use, general mental health, or other health-seeking behaviors. And so I pulled their data on what substance use was looking like among the adolescents. In 2018, we saw a dramatic increase in substance use, specifically within vaping. Not only nicotine, but marijuana use, highly reported in 17 to 19-year-olds, which increased 3 times across grades 8, 10, and 12. The one good thing with COVID, I suppose, is that there was actually an overall decline in substance use among these adolescents in these grades, probably relating to being quarantined and not having access. And luckily, that decline remains stable into 2023. So I think this speaks a lot to how important it is that we don't have exposure and our environment is not offering substances, how much that actually can impact things. And then also just thinking about the cohort effect. So if we have a cohort that has higher use, that's probably going to continue on moving forward. Whereas if we have a cohort like from 2020, where we have a reducing use, that seems to carry on or kind of plateau over time. Next, we found that marijuana use was still considered to be quite high among grades 10 to 12, over 0.25% being reported in 12th graders. And again, remember, this is across 50,000 adolescents being interviewed, so still a significant amount of use. In 2018, saw the arrival of Delta 8, which is a synthetic cannabinoid. Kind of shocking how many were being reported as using it in 12th grade, as this was a new substance we didn't know was going to impact people. So can continue on to the next slide. Next, we must talk about pediatric deaths. So this was retrospective data that was pulled across kind of CDC reports. This was anything related that was marked to an substance-related overdose deaths in ages 14 to 18 per 100,000. So comparing that to the average population, just to see what the rate of death was. The top numbers are related to just any substance type overdose, so not specific to fentanyl. We see from 2019 to 2020, 490-ish deaths up to almost 1,000 deaths. And again, these are of 14, 18-year-olds. 2021, over 1,000, so that's 5.49 deaths per every 100,000. This was almost a 94% increase in deaths from 2019 to 2020 alone. And then specifically next, looking at fentanyl, so how much fentanyl related to those deaths. In 2019, fentanyl-related overdose deaths went from 250-ish, 2020 into the 600s, 2021 increasing still almost to 1,000. So fentanyl was found to be due to almost 77% of those cases of overdose, which compared to just 13% of it relating to benzos. So again, a lot of overdoses related to fentanyl use and exposure. Next slide, please. Next, I was curious to know what pediatricians, how they feel about this and what their experience has been. So I dug to see if I could find any qualitative studies. I found one, and it looked at a few different metro clinics across the states and interviewed 75 primary care providers that worked with the pediatric population. And they said the following: a majority said that they do talk about substance use, and they'll specifically ask about illicit drug use in adolescents. Unfortunately, almost all those providers did perceive barriers in implementing a brief screening tool, an intervention for that, and knowing how to refer to treatment or what resources were. Other common barriers were parents being present, not having the time or built into their workflow, and even if they did encounter an issue, having lacking resources for it. Almost 50% reported having no formal training in this. We can go to the next slide. So again, as I'm sharing with you all this data on how much of a problem this is, and saying that primary care providers are at the forefront, unfortunately doesn't feel that they feel equipped or prepared all the time to do this. You can go to the next slide. Next, we have to ask the question of, what does age of use mean? How does that correlate to later use disorders? So here's two graphs that look at both people with alcohol use disorder and then what I might say is cannabis use disorder. And then they looked at when they first started using the substance. And there's a pretty clear correlation with the younger of first use, more likely correlating to that use disorder later on. If you look at the end of the graph, which is almost comparable and quite similar on both ends, if they were using first at age 13 or younger, it's almost a 50-50 chance they later develop that use disorder. Go to the next slide. And then overall, when does most substance use begin across the lifespan? Unshockingly, it's going to be in that adolescent period. So most commonly, we're going to first start using substances at ages 16 to 17. I think a lot of us probably know this, so I actually want to direct your attention to the end of the graph on the right there. Ages 26 or older, it's almost abysmal. So really, if we can get out of that adolescent period and avoid using substances, it's very likely people will not end up actually using substances at all. So we'll continue on, Ryan. In summary, overall, adolescent substance use rates are down. However, the lethality of substance use is up. So while there's less substance use overall, there's still that fentanyl exposure. Deaths are still increasing because the use of what is being used is just getting more lethal. Primary care providers are at the forefront of primary prevention of this, but do not always feel trained in implementing this process or supported in doing it, even if they obviously knew how. We also know that the sooner substances are used, the more likely a full use disorder could develop. So again, really equipping that forefront and helping primary prevention is so important, and knowing that preventing 1 year of use could be instrumental in preventing later substance use disorders from developing. Next slide. Okay, so next, just threw a whole bunch of data at you. We're going to bridge into the neurobiology and substance use. So first, let's look at this beautiful picture of our neurons. Beginning at birth, we see not a lot is happening there, not very many neurons. We're growing our connections. We're just developing our brains. At age 6, it appears there's a lot more going on than age 14. Not to say that we lose our neurons or that we lose our intelligence. It's more of the blooming period, when this is the point when we're kind of like a sponge. This is when we're our most malleable. Your brain is looking to see what connections and things we can take in. So this is the idea of a young child becoming fluently in a language very quickly, versus as we get older, it's more about honing in those connections of what neurons we're using. So your brain is going to pay attention to what you've been using and hone that in, or form more connections, myelinate those connections, make those connections more efficient, where we start mastering things. So it's the idea of what you don't use, you lose, and then what you're using, you hone in on. So again, so important of what we're doing with our brain at an early age, how that sets us up in later life. Next slide. And then brain maturation over time. So this is a scan looking at brain matter and kind of the process of how our brain develops. We see those lighter colors are not full maturation, whereas that darker blue to the purple is going to be complete maturation of the brain. Just want to point out that at age 20, we still have a bit of maturation to complete. So still takes quite a bit of time for those brains to mature. And then next, going to the process of how the brain develops and what pattern in the way that that development occurs. So it begins at the cerebellum. You can go down, hit next. We'll see this little kiddo pop up. So this is just pointing out that it starts with when we're little, we start crawling and moving, we're walking around. You hit the next arrow, the little kid will pop up there. Yeah. Then we can go to the next slide. Next, it's our amygdala is going to start developing. So this is kind of our fight or flight center, our emotional regulation and processing center. If you hit next, you'll see the screaming 2-year-old. So this is the idea of the terrible twos, that we're still directly learning how to even process emotions. So this is the concept of why toddlers can, at the drop of a pin, have a meltdown and then seem to be fine with no reason. Off and on, our emotional centers are developing. There's our crying child. Next, we have our nucleus accumbens. So anyone who works in addiction should know that this is kind of our big addiction center of the brain, right? Where we get our reward achievement center. This is developing in school-age children. So this is why we think about those kiddos. They're so goal-oriented. They're so happy to appease adults and join in on the fun to feel that they can be helpful and industrious. Next slide. And then lastly, in adolescence, we have the prefrontal cortex developing, our lovely gas pedal to our brain, helping us with impulsivity, reasoning, and long-term planning to help with impulsivity. Next slide. So this graph is pointing out that, hey, adolescents have their nucleus accumbens fully developed, which is our desire to hit the gas pedal, but our prefrontal cortex is still developing, which is our brakes. So this is why in adolescence we have that desire to always be looking for award or risk-seeking sorts of things, but we don't always have that impulsivity and that long-term logic to think to maybe put the brakes on. Next slide. So this was a really interesting study they did. They took 3 different age groups and they looked at children, teenagers, and adults, and they gave them first a small stimulus and then a large stimulus or reward. And then they looked at how the brain lit up or got activated in each age group depending on how they reacted to the small reward and then the big reward. And what they found, first of all, if you look at the children in the blue line, they had kind of an equal response. Whether they had a small reward or a big one, their brains really lit up. They really just loved that sense of achievement. Again, their nucleus accumbens is developing, so that all aligns. Think about the little kiddo that gets so excited over just like a sticker or a thumbs up. They're pretty happy with that. But then adults, we look at adult brains, that's the green line. We see a little bump with that small reward, and we see a bigger bump with the large reward, which seems to align with what we'd expect. Teenagers are interesting. They kind of have an inverse reaction, actually. Their brains seem to be almost off-put by a small stimulus in comparison to a large reward. So imagine if you were to tell a teenager if they did something for you, they would like earn a sticker or a thumbs up. That's like you get a big eye roll. They don't care that. In fact, maybe they just don't want to do it anymore. But on the contrast, that large reward, they're so much more sensitive to it. Look at how much bigger their bump is than the adults. So going into the next slide. So in summary, adolescent brains are greatly primed for larger reward-seeking behavior, more so even than adults. Adolescent brains respond more sensitively to rewards, despite still developing in areas of judgment and long-term reasoning. So again, hitting a whole lot of that gas pedal, not really hitting the brakes. This all will increase vulnerability for high-risk behaviors, the substance use, which could create risk for developing later adult use disorders. So then that'll bring us into a nice leeway next. Next, we'll talk about the 3 key substances that adolescents use, or the most common substances used. It's not shrooms. I know I put a picture of mushrooms on there, but we can go to the next slide. Okay, so starting with alcohol, here's a lovely picture of your alcohol molecule. You'll see that oxygen and hydrogen on the end there. It's a hydrophilic chemical, which means that it can easily pass through membranes, and it can create a whole lot of interactions in the brain. It can easily have a whole bunch of impacts in the body. Next slide. 90% of all alcohol that is consumed by underage drinkers will occur in the context of a binge. So for all of your review, and according to SAMHSA, a binge would be 4 more drinks for women, 5 or more for men. The difference there is because we metabolize alcohol differently. So basically what the takeaway is, if a young person is drinking, they're likely doing it in a high-risk, risky sort of context. Next slide. Okay, so here's what's interesting. This was a study they did to show that, in fact, adolescent brains are impacted by alcohol or intoxication differently than the adult brain. And obviously, they did this with rats, because what else are we going to do these studies on? So they took 2 rats and they had them swim down 2 water lanes, and they took an adolescent rat and an adult rat, and they got them both intoxicated. I'm not really sure how you do that with a rat. But then they went to see if one would be more efficient or better or could more quickly reach the end of the swimming lane than the other. And what they found is that both were equally impaired. They were just impaired in different ways. The adult rat was more sedated and weighed down and wasn't able to get to the end because it was slower, whereas the adolescent rat wasn't weighed down, sedated at all. It was just so motor impaired that was swerving all over the lane, unable to reach that end just because there wasn't that coordination. Next slide, I'll tell you why this all matters. So what this all comes out to is that adolescents are more likely going to feel more invincible, less actually inebriated than they actually are, despite the fact that they are very much impaired. So this is a study that shows the differences in ages. So the light gray and the dash gray lines are going to be those older people, 20 to 30-year-olds, compared to those darker dash lines being our teenagers to young adults. And they looked at blood alcohol levels, so the amount of alcohol consumption related to very bad car accidents, fatal car accidents. And clearly we see a correlation with more alcohol use and fatal car accidents. But what you will still see in comparison to that increase is when you compare the black lines to the gray, there just is a greater incidence overall in the young people coming into these incidences. Again, speaking to the fact that a young person is more likely to get behind the wheel and feel that they can drive versus an older person who might more likely feel the impacts of that alcohol differently. Next slide. This is just speaking to what drinking does in the brain over time. So we have some brain scans that compare the activation of the brain versus deactivation from a 16-year-old to age 20 and first a non-drinker over time to a heavy drinker. And as we're probably not surprised, we see the heavy drinker over time, we have less activation in the brain. So again, some neurological impacts happening even from a young age on in those 4 years from ongoing alcohol exposure. Next, we're going to talk about nicotine. So here we have the nicotine compound compared to our acetylcholine, our endogenous version that we have in our brains. So as a review, acetylcholine is going to be our pro-cognitive neurotransmitter. It's going to be kind of what helps us learn and gain information in the brain. Nicotine is going to go in and sit on those acetylcholine receptors. Okay, so next this is a graph showing what different nicotine tobacco product use has looked like in adolescents over time. So if we look at the white lighter lines down to the blue and the dark lines from 2011 to 2018, overall you'll notice this trend of reduction in nicotine use and overall reduction in cigarettes, which I think was a wonderful public safety outcome actually with all the announcements and campaigning they've been doing. However, what's circled here, if you look, that is specific to e-cigarettes, which in 2018 we really saw a big bump there, which unfortunately correlated to an overall bump in use of overall other nicotine products. And this was the year that the Juul came out. That was the new e-cigarette that looked really almost actually like a computer insert. And there was the arguments that clearly it was marketed towards young people, and clearly young people had increased use of the e-cigarettes, and that led to overall increased use of nicotine. So just pointing out that marketing and exposure is very important. This is showing all of the neurochemical impacts of nicotine in the brain. So it might shock you to know that there is still some GABA release, or inhibitory calming chemical of the brain is in fact being released as well. This could speak to why in the adult world, sometimes people actually describe they smoke a cigarette and they feel like it calms them, versus some people might smoke it and feel it gives them a buzz or helps them wake up and focus more in that initial period. We'll talk about how that differentiates with adolescence, but what you want to pay attention to here is that dopamine. So dopamine being our big reward neurotransmitter is living in the ventral tegmental area at the center there over to the nucleus accumbens. So directly in our addiction center is where that dopamine is going to release after the nicotine sits on the acetylcholine receptor. Not only that, it's going to project out to a prefrontal cortex. So again, just showing that it is having cerebral impacts, and that in adolescence, that area is still developing. And this is why it's hypothesized that adolescents at increasing rates will develop addictions to nicotine faster than even adults. And then this is, I'm not going to read these all out for you, but if you scan it, you'll see the contrast of the impacts that the subjective reports that nicotine have on adults versus adolescents. Long story short, adolescents get more of the fun effects. They don't get much of the negative. They feel it enhances things. It makes them feel more motivated, and adults are more likely to get maybe some of those negative effects or lack of that buzz sensation that adolescents do from nicotine. And then lastly, just want to speak to the still very unbenign chemicals that are in e-cigarettes. So I don't know about you, but I have a lot of patients who will come to me and say, don't worry, it's harm reduction. I'm trying to cut down on smoking, so I'll just switch to e-cigarettes. And I mean, I take a harm reduction approach. So overall, it's going to help them cut down, then I'm for that. But it's so important for people to know that there's a bunch of chemicals. They've reversed chemically analyzed these, and there's like 60 to 70 chemicals across brands, and a lot of them are not benign at all. So just to list a few, we've got a chemical from volcanic emission in there. We've got some embalming fluid. We have some poison, chemicals that have been used in water treatments. So again, just important to note that we don't actually know what all these chemicals do, how carcinogenic they are, long-term impacts. Okay, so now let's specifically talk a whole bunch about cannabis. So next what you're seeing is the THC molecule compared to our endogenous molecule anandamide. So I know in our brains we talk about CB receptors. Our brains were not built for cannabis. We don't have cannabis receptors in our brain. It's actually our endogenous molecule anandamide that THC mimics is going to go sit on those receptors. It's just that we discovered this after the THC. So I'm going to put this into lay terms. When we talk about cannabis today, I want us to think about it in two components of the plant, either CBD or the THC. CBD being the really more inhibitory component, will usually inhibit actions of THC. THC is going to be more that psychoactive, more addictive component. So for addiction reasons, when we talk about high-risk cannabis use, we're always about how much THC is in a product. That's going to be the component that we're focusing on. Something else interesting to know is that the way these receptors work naturally in the brain is that usually when our neurotransmitters are communicating, they're going to get a signal from the dendrite, go down the axon, go through the synapse, go to the next neuron. But actually what's going to happen with THC on these receptors is it creates a retrograde action. Naturally what happens is that these receptors modulate how our neurotransmitters actually communicate with each other. So it actually directly impacts how our brain functions. So next slide. Okay, so this is all the impacts of THC in the brain. It has a lot of impacts across the brain, starting at the cerebellum. This speaks to why when people feel like they are high if they're smoking weed, that they feel slowed down, or they potentially even ataxia at high amounts. Look at all of that impact at the cerebrum and the cortex. I mean, this speaks to the slowed thinking, reduced processing, poor concentration. This is why, again, if we have patients coming to us saying they think they have ADHD and they're using a lot of cannabis, it's important to have this discussion. And then finally at the center there, once again, at the nucleus accumbens, our addiction area, a whole lot of THC acting directly at our addiction center. Next slide. And then here's an interesting graph that depicts that the more cannabis that's being ingested has been directly correlated with reductions in hippocampal volume. So the more cannabis exposure, there's been very real found brain shrinkage. Again, our memory center of the brain, I will tell you from experience, I've worked with an adult who at age 50 had really chronic heavy cannabis use for many, many years, and just did not have memory. He was losing so much memory, no memory retention, and almost presented like an early dementia picture. And then here was a study that really hit home for me that's important to think about with our young people who are using cannabis. So they did a cohort study where they followed groups of people, those who had never used cannabis, those who had used but it wasn't consistent enough to be like a use disorder, and those with a use disorder of cannabis, so there was enough heavy ongoing use, first for a year, 2 years, and then 3+. And they tracked their IQ points over time. And the only positive correlation we see is in those who never used cannabis, having like an increase in their IQ points. Or as over time, we saw that there was this ongoing negative correlation with ongoing longer cannabis use directly following with a reduction in IQ points. And if you hit next, I can't remember how many, I think it was a reduction over time of 3 IQ points. So we saw on average, those who never used had an increase from 99.8 to 100.6 in IQ. On average, those with 3+ years of use had a reduction from 99.7 IQ down to 93.9. So not a huge jump, but I really think this deeply speaks to the neurotoxicity of cannabis and how much it impacts us. Next slide. And not only cognitive impacts, really significant psychiatric impacts. So this is a study that they did at Boston Children's Hospital. They surveyed 500 adolescents who were coming from primary care providers within their clinics. And they asked them, of those who had used cannabis, have you ever had any of these experiences of psychosis or psychotic symptoms? And I just want to point out, over a quarter endorsed hallucinations. Almost 50% have reported any psychotic symptom. Now, as a psychiatric provider, I like to tell people when people have a psychotic episode, even briefly, it's kind of like the brain had a small seizure. It's really damaging. And really, it's almost like a kindling effect where it increases your risk of something like that happening again. Really, really harmful. So the fact that this is happening so frequently being reported with cannabis use in young people is very concerning to me. Next slide. Next, I want everybody to take home this point, no matter what your patients tell you, because they will come to my office and they will tell me, don't worry, it's the natural plant. I have a friend, they're growing it. It's as natural as it can get. It does not matter. This is not your parents' cannabis. This is not what the plant used to be. Even if it's a naturally farmed plant, over time, the plant itself has been rebred so many times with the focus on kind of isolating in those THC components that it's no longer having that original makeup of all those thousands of chemicals it used to have that naturally typically would probably kind of counteract some of the more potent sides of the plant. So over time, even if you're getting a natural plant, it's most likely going to be more potent. When I'm saying potent, I'm speaking again to THC. So again, all of this that we're talking about, any negative impact, we're really honing in on the THC. That is the potential neurotoxic component of the plant. That is the part that is more addictive. So if you look at these pictures at the top, if I were to say this is cannabis, you probably wouldn't have assumed that. On the far left picture, that is cannabis oil. The middle and on the right, that is cannabis wax. So those are the things that are going to be in what are called dab pens. That's the really concentrated THC up to 90%. Which, just to give you a timeline, in the 90s, on average, the THC percentage in cannabis was 15%. That compares to an 80 times increase in 2020, where we have these products where you have up to 90%, almost 99% potency of THC. And then next, if you reference my pie graphs there, so this was a case control study I looked at where they looked at different regions in Europe that were known to have high uses of cannabis, and they isolated those regions. What they did is they looked at patients and inpatient psychiatric units who were there for an episode of psychosis, and they pulled apart the ones who had cannabis use from ones who are representative more of the normal population, and they took odds ratios of it because they wanted to know, what is this risk if you're in a region that has higher cannabis use, and not only that, but specifically higher potency cannabis use, that you might end up seeing more of these psychotic episodes. And what they found was a 5 times increased risk of psychosis related to cannabis if you were in London, and a 9 times increased risk from psychosis related to cannabis if you were in Amsterdam. So 50% of the cases of those in Amsterdam that were there for psychosis related to their cannabis use compared to 30% of those in London. And that directly was found to correlate with not only the amount of cannabis in those regions, but the potency of the product in those regions as well. So you can go to the next slide. So what do you do with this information? What do you tell your patients? A quick summary is just, hey, obviously I'm always honing in on adolescents because their brains are developing. This is a chemical that will make you dumber. It just will. It's just so harmful to your brain. It can make you psychotic. It can lower your IQ points. School's already hard enough. I don't recommend you use this. But if for some reason you're going to use something, please avoid those dab pens. Avoid wax and oil. Lower potency, less THC, the better. So I was curious of what recommendations were. If you look at the Minnesota Department of Health, they say that technically you don't want to exceed 20 to 40 milligrams a day of THC. CBD is a lot higher because it's more of a benign component of the plant. There was really negative things found in studies. I will tell you in some studies that I've looked retrospectively just in case reports that there's been negative findings from THC as low as 7 milligrams with loss of coordination and perception as low as 30 milligrams. Going next to the slide, or next slide. So how does that translate to use? I'll just highlight really quickly. If someone's smoking a bowl, that is going to be 0.5 gram or 500 milligrams of cannabis, and you take the percentage of THC of that. So let's be super nice and say this is the 90s, and we have low potency THC. 15% of that already is up to 75 milligrams of THC. So already, if you're smoking a bowl, you are exceeding that recommendation. You're likely to have negative impacts from your use. If you go to the next slide, I honed in on gummies. I was curious to know a local dispensary. So what's important with these gummies is that they're usually all THC concentrated. It's usually not CBD. And you got to look at how much THC is in each gummy and if it's actually the full gummy or if it's half of gummy. So Colorado had this problem actually where people were taking all these gummies or a full cookie when really half of that itself was pretty potent, and they were having neurotoxic events. They were getting suicidal. They were becoming psychotic. There was an increase in ER admissions. So I'm not sure if they ended up having to change how they do their labeling, but this is significant. So in summary, this is a handout I made in fellowship. Don't have it here. I don't have anything vetted here. I will be working on something. But in summary, it'd be nice to have just a quick educational tool or a visual just to say, hey, the lower THC content you can have, the better. Like, know what is in your weed. Usually teenagers are okay with talking about, like, if they're talking about, yeah, I'm smoking weed, ask them, what kind of weed do you use? And sometimes they don't know. And you just explain part to them. They're usually actually pretty open about that. Next slide. Okay, so lastly, we'll wrap up and talk about now how do we assess for these issues. The American Academy of Pediatrics wants everybody to know who works with this population that overall we should be implementing SBIRT, which is screening for a brief intervention and referral to treatment, and push the non-use message overall for any substances. So here's what this looks like. If we break up SBIRT, here's what it stands for. First, we screen. So we use our screening tool. We should really be doing it for anyone 12 or older. We want to standardize it so we're not like unintentionally discriminating. So everyone equally is getting screened. Then you want to use that screener to determine if there's risk for substance use or use disorder. Then you determine your intervention or if they need to be referred. So here's a screening tool I will offer to all of you. This is one I actually was working on implementing at the JDC down in Iowa, simply because it's really easy, straightforward, and it's quick. I know a lot of us don't have time in clinic. This is something that's really straightforward. So you give it to your patient, you have them select of all the substances, how often they use any of them. Next slide. Depending on their answer, you'll see that correlates to the level of risk. So either they're not using or there's low risk, moderate use, and then it could align with this very high risk of a substance use disorder. Next slide. And it's important, I just quickly want to put a plug in to know that one-time use, even if it's a really risky substance, does not equate to an addiction. The quick and dirty of this is the 5 C's. So if there's not consistent use, you can't have an addiction because it has to come with consistent compulsive use. Now, if a child tells me they used meth once, I'd still be worried about that. That's still very risky. But I just want everyone to be clear that doesn't, like, you can have high-risk use without an addiction. So you usually have to have consistent use, cravings, loss of control, compulsiveness, so an ongoing return to use, and then consequences. So we're continuing to use despite consequences. Next slide. So let's say they do the screener. They're saying they're not using anything. You just reinforce that use message. You get positive reinforcement. Let's say they are using a bit. You could give some brief advice like, hey, here's the risk of this. If it's cannabis, maybe try to lower your THC. Maybe try to avoid synthetic or more toxic products. Let's say there's more moderate use, there's more of a risk, we're more worried about it. This is when you give that intervention of, hey, I'm really worried about this. Maybe you should go see somebody about this. Here's treatment options. So that's the brief intervention referral treatment. Next slide. We don't have time, I believe, to go through these case scenarios. I just wanted to tease through like scenarios of if an adolescent said certain things. Is this like high use versus an addiction? And what would you do with this? At the very end, feel free to skim through this. And if you want to ask me or run through it, you're welcome to. Okay, go to the next slide. Okay, I do want everybody to know about this. And this is something I personally handed out, and it is wonderful. Great harm reduction. Has anyone heard of the Contract for Life? Okay, so this is an organization that really was just trying to prevent teenagers from getting into cars in high-risk situations. So what this is saying, like, I get it. You're at a party. You don't want to get into trouble. What if we came to an agreement where you pick a safe adult who's not going to judge you? So the agreement is that you will never get into a car with someone who's been using. You're going to call your adult, and they're going to sign this in return and say, I agree. I'm not going to judge you. I'm not going to punish you. I'm not going to ask questions. I'm going to show up. I'm going to pick you up. I'm going to keep you safe. This is actually very effective in the adolescent population. So it's as simple as just handing out this paperwork and kind of having this discussion with the kiddo. The link for this paper is placed there. And here's just a summary of some quick educational tools. I'm all about visuals, so are patients. I like to hand out the alcohol consumption thing often. That's a quick way to know how much they're actually drinking. Don't ever buy if a patient tells you how much they're drinking. You got to ask them, like, actually, what's the cup? Like, what is it? Point at the picture. They might think it's a fifth and actually it's a handle. Teenagers do a lot of like pulling from the bottle. So sometimes it's actually helpful for them to realize if you point out, let's say they went through a liter with their friend, point out how many shots is in that thing. Like, this is how many shots you just consumed. And then there's a picture again of all those chemicals that are in e-cigarettes. And then lastly, some fun bullet point facts I like to share with adolescents as well regarding cannabis use, of it not being benign, is that there was risk of popcorn lung if they're vaping or smoking it. That was a strange occurrence that was happening for a while. We do know it actually shrinks your brain. It does. That's a known fact. There's a risk of psychosis and getting stuck on a locked psych unit. Pretty scary stuff. Lastly, teenage boys are pretty motivated by this. Heavy, consistent use can reduce sperm count and reduce your testicles. So probably want to avoid that. You can go to the next slide. So here's a nice summary table. Let's say you screen your adolescent, you're seeing some risk of use, you want to refer them, but they want to know, or the parent goes, what are options for this? Like, what do we even do? Golden standard across the board is going to be dual treatment. It's going to be like a therapy programming where they do something for mental health and addiction, where they can also do family therapy if possible. There are certain medicines that can help with cravings and reduced use for certain substances. So for alcohol, I have personally actually for teenagers, you can give them naltrexone. That is something that is an opiate blocker that's helped in theory to block those endorphins that are sometimes released when people drink alcohol that in theory can help reduce cravings and the amount of heavy use. That comes in a monthly injectable medicine, so it's good for adherence. And then if someone is concurrently for teenagers using opioids, that's another one. It's going to block fentanyl. It can prevent from an overdose. So naltrexone is one option. Acamprosate has less evidence, but still possible to use. That's another medicine we use for cravings and to help cut down on alcohol in the adult population, less studied in teenagers. Cannabis, we don't really have any good findings for any medications for cravings for that. There was one kind of non-rigorous study done in teenagers that said maybe acetylcysteine can help, but I haven't personally found that to be true. If they become psychotic from cannabis use, then they might need inpatient psychiatric treatment and a short course of the antipsychotic. Nicotine, you can give teenagers nicotine replacement. I've had pediatricians ask me, and you can. I'd rather them have that than continue to smoke nicotine and help them cut down. Wellbutrin is technically an option. I will tell you I'm biased. I'm not a fan of Wellbutrin. It's too lethal if people overdose on it. And I've had a lot of teenagers divert it and snort it, and it kind of acts like meth that way when that happens. But I will tell you that if there's any risk of suicide and if the kid overdoses on Wellbutrin, on my toxicology rotation, I did see a pretty near death on that. That's pretty serious. So I'm not a big fan of Wellbutrin, but just know technically that's an option. Opioids, again, you can give Suboxone to teens. It's approved in 16 and older. Really good evidence to help reduce use. I don't want another kid to overdose in fentanyl and die. So for me, that's huge. That's really important. There's Sublocade is the long-acting monthly injection of Suboxone that again can help with adherence and protect from an overdose. Methadone technically can be done, not so often because usually you have to be 18 and older. There's a whole bunch of hoops to jump through. That's a much higher risk medication, but it technically has been studied and can be done. And then we spoke about naltrexone. Finally, let's say you decide to refer to a specialist. Please know our location and our contact if you're ever within our system or want to reach out to us. We do technically see the lifespan. Any questions?
You know, Alex, this is Kurt. I'm just wondering if you could just comment a little bit on, like for instance, when I see somebody who's smoking marijuana that's 15, I'm not talking about their lung cancer risk, right? Because they don't even hear that.
Yeah.
Right. Do you want to just comment a little bit on how the conversation goes as an adult compared to an adolescent?
Like how I would talk to an adult about it versus a kid?
Yeah, well, mostly how do we talk to a kid about it that's different than adult?
Yeah. So kids are really receptive to like the lingo you use too. Okay. So the minute you start talking their language, they're going to pay attention to that. And the more like casual laid back you are about it, the more they'll talk about it. Kids that use drugs love talking about drugs. So I usually start with like, hey, so you're smoking weed. What do you like weed for? Like, what does it do for you? And they might say like, I don't know, it chills me out, or I just do it with my friends. Okay. Are you smoking it, eating it, vaping it? Like, how do you use it? And then they'll kind of tell me about that. And I'll say, what kind of weed do you use? And they kind of stare at me sometimes. They said, well, is it like dab pens? Are you using wax? And at minimum, they're usually actually pretty receptive to the discussion of, I wonder if you'd reduce the potency, because I'll usually say there's actually some side effects people don't know about from a lot of THC. One of them is this really terrible vomiting that doesn't stop. Have you ever have a friend have that happen to them? And surprisingly, I can't tell you how many times teens go, oh, really? Or they'll call it greening out. I'll say, yeah, that is from like too much THC. So if you can just lower the amount, that would be better. Technically, we know that it can actually shrink people's brains. Like I usually say in kind of these terms, I usually say you're going to do what you're going to do, but I know that you're a smart kid. I know that you should know what's in your drugs. You should know what's happening to you. Here's some of the things that can happen. And as your doctor, I'm worried about that. I don't know what your thoughts are. And just kind of get them to have the conversation, if that makes sense. If you can at least start there. Does anybody have any other questions or thoughts?
I do. Just in my observations with my adolescent nieces and nephews, it seems like smoking tobacco we're kind of trending away from that, and kids are definitely more health conscious than they used to be. So, are you seeing that people are using ingestibles for THC at a broader level than perhaps vaping or smoking, or is it still kind of linear?
Are they, sorry, did you say, are they consuming like more of the gummies versus the, well, my perspective is skewed because being in a specialty area, I tend to see more severe cases. So I'm going to see the kiddos that are using really hard drugs, or I'm going to see the kids that are, they might come from like, I don't know, they might come from lower income areas where it is more common for them to smoke cigarettes. I will say, trying to think back, it's hard because honestly, the populations I see are, I used to work with a lot of JDC kids, like from juvenile detention. I think vaping across the board is going to be more common than obviously like cigarette use. I feel like with the population I've seen, it's a lot of the dab pen stuff, which I worry about because of that THC content. Probably equally with the gummies, I would say. Which harm reduction wise, it's still better on the lungs, but I'm always thinking about THC content.
Right.
Yeah, sorry. I actually don't know if I'm a good person to ask because usually, or when I was inpatient on the psychiatric unit, it was kids who were like, it was really high potency stuff that you get psychotic. And that's why I was seeing them because I can't tell you how many teenagers I saw come in floridly psychotic. And I used to think it was because something was laced in their cannabis, and it's not. It's about the THC potency. And sometimes they don't go back to baseline. It's really scary.
I think my question was very much along the lines of Kurt's. What resonates with people, both adults and adolescents, to let them know that there is risk associated with cannabis use? Because, like you said in your presentation, most folks comment, yeah, it's safe, it's natural, it reduces inflammation, I sleep better, my anxiety is reduced. So it's hard to talk patients out of their THC consumption.
It's medicine.
Yeah, and I feel like it's even harder to do that with adolescents. Speaking from personal experiences with our stepdaughter, like vaping and using THC, we've had some challenges, and it's just a difficult conversation. So, any pearls or things that really resonate with people, like do you go at them with the shock factor, or like what's your canned phrase?
Well, with the JDC kiddos, it was different. With them, I have a whole presentation specific to cannabis actually, and I have a video on there, and it was a lot of like, I would engage them in conversation because they want to be a part of it. They want to argue with you. And I would try to meet them in the middle. It was like a part of a game. Actually, it was a poll where I would say, true or false, is cannabis medicinal? And then they would answer, right? And then I would explain like, it's yes and no. Or it's like a yes and, because CBD can be helpful. I do agree with that, but THC is not. And then I would ask them if they've ever seen a psych unit and do they know what psychosis is. And for some of them, because it's such heavy use, they'd seen it in friends and that was scary. But I'll be honest with you, that's not going to be useful in that population. What's usually useful is figuring out what they're motivated by. What do they want? So if you have a kid who's really into sports, or let's say they actually are pretty studious, or they actually like want to do well, then say, man, like that sounds really awesome. I wonder if you could, like, I bet you could go far with that sport. I bet you could do a lot with that, right? But man, I don't know how you feel about smoking weed with the sport. And they probably say, what do you mean? Well, I know a lot of people your age, they got kicked out of their sport because they were using, or if they're into like, I don't know, academics or something, like, man, I can tell you my teenagers talk to me, they notice they got dumber. Have you asked your friends, like, have they noticed they feel dumber since they've been using? Like, that sounds kind of, it's almost like suggesting. You're not telling them to do something. The worst thing you can do is tell an adolescent what to do. It's more of suggesting things and being curious. And sometimes I'll twist it or phrase it as, like, I want to empower you. Like, you are going to be an adult soon. Don't you want to know what's in your drug? Do you know how much money the government makes off of you and how they're doing it? Sometimes they turn into a control thing of like, do you know that they're actually increasing the potency of THC because they know you'll get more addicted and then they'll get your services and really they're just screwing you over. They don't care about you. My teenage boys in JDC were actually pretty receptive to that. I often talk to them about like, don't be another statistic, prove them wrong. How many of you have been called like delinquents in here? And they, get them kind of like amped up, motivated, excited. Like, let's do it for the cause. Let's resist something. I don't know. It's not like a perfect answer. It's kind of.
Oh, thank you so much. I jotted both of those down. I love the what motivates you. I think that's such a savvy way of going about it. Definitely.
And I honestly, sorry, go ahead.
I was just going to say, it's really funny too. And, in our clinic, we will see people who are in their teens and they're smoking weed and then they feel like they have ADHD, right? And they feel like they need that evaluation. Well, so are we going to take somebody who's using a drug that totally messes up their cognition and put them on a drug to try and improve their cognition? And I often have that conversation when I just don't know that we can go there if you're smoking weed. And I have a lot of conversations about the IQ, just like Alex. It's like, what's your goal? Do you want to go to college, and do you want to give up 6 IQ points when you're in college and it's competitive? I mean, do you really want to do that? I'm more about everything in moderation, and it's like, hey, if you smoke weed once or twice a month, it's not going to drop your IQ 6 points. But if you're doing it every day, yeah, we're going to go that direction. So they don't care about long term. They care about this year, next year, maybe, right?
Yeah, exactly.
I have one more question for you. So vaping is so potent and most kids can't tell you how much they're actually vaping. Kind of hard to measure, right? So with nicotine replacement therapy, are you sticking to like the recommended doses or are you going higher to compensate if someone's heavily vaping?
So technically, the way I get an idea, and I'd be curious, maybe Kurt does this differently, but I ask them, first I have to figure out if it's a disposable cartridge or if it's like one of those disposable vapes. I ask them how often are they either going through the pen or are they going through a disposable? Because if we're going through it weekly versus like throughout the week, that tells me like how much use. The next question I have is, are you waking up and vaping immediately? Because if we're waking up and vaping immediately, then that tells me I'm going to more land for that moderate dosing, most likely that 14 milligram patch I probably would still stick with the 2 milligram gums or lozenges, but versus if they're telling me I'm going through a cart like once a month, then I might say, okay, maybe we can try lower dose first and we can go up if needed. If that kind of makes sense. It's not a perfect science, but.
Yeah, I always remember what Charlie Resnikoff said, which is more is better. It's like, and he's like, man, you just put on 2 patches if you need to and add Wellbutrin and do all this other stuff. He's like, much like Suboxone, we probably underdose. And I think that Charlie's big thing was I put on as many patches as it takes to stop their symptoms. So it's like, okay, but
Yeah.
that's Charlie.
I'm really stingy with medicines with young people though, as I was kind of expressing to you all with the Wellbutrin even. Like my time on inpatient psychiatry, man, those kids got loaded up in so many meds to just try to behaviorally regulate. I really try to avoid that if I can, at least till they turn 18. I personally just feel really protective about that.
All right. Well, I think we're getting near time. Any other questions for Alex? A lot of nice messages to you, Alex, about the talk. So
I got a quick question. You mentioned the kids who are psychotic and it's just the THC, but is there a safety factor of using edibles where you have somewhat better idea of how much is actually in it versus smoking where you don't know?
Oh, you mean like if someone says, okay, I want to try to do this in moderation. So how do I know how much I'm taking in? Is that the question?
Yeah, and not get other stuff that might be mixed in with it.
Potentially, but the problem with that is that you're believing the dispensary because again, we have to remember it's coming from a plant, right? So what plant is it coming from? Was this like a hybrid plant? Was this a more potent plant? Where was the gummy manufactured itself? Also, I should have told you all that Delta 8 and Delta 9 are different things. The Delta 9 is essentially supposed to be that pure THC, where if it says Delta 8, just know that is a synthetic cannabinoid. That is not the same thing as THC. I can't guarantee in whatever amounts what that's going to do to someone's brain. So in theory, you could try to measure it that way, but I would still approach that with caution and say, we still don't actually really know what's in all those products because as we know, it's not like it's FDA regulated. So.
all right. Well, thank you so much, Alex. She's already got some ideas for another talk, Aaron, just so you know.
Beautiful. Love it. Thank you so much for coming.
She's planning ahead. So, all right. Thanks, Alex. And thanks, everybody, for showing up this week. It was a nice group. And if there's any questions, please reach out. I'm sure Alex will be happy to answer any other questions. You can always email us. We can forward them on to her. Otherwise, we will see you in a couple of weeks. And I believe that's when we have Cole Peringer on.